Welcome, everyone. Today, we're doing something really cool. We're taking a literal 1000x zoom straight into the anatomy of the eye. In this explainer, we're doing a clinical deep dive into the mechanisms of action for ocular diagnostic agents. And we're drawing this directly from the incredibly insightful clinical lectures of Dr. Dirk J. Boyesen. We're going to explore how just a few tiny drops of liquid can entirely map out cellular health, completely halt pain signals, and literally hijack the autonomic nervous system.
Okay, let's dive into this with a brilliant analogy from Dr. Boyesen. He actually compares practicing ocular therapeutics to flying a vintage Tiger Moth aircraft. Think about it. You wouldn't just jump into a vintage plane and take off without doing a rigorous check of the engine, right? Well, similarly, our clinical exam and the diagnostic agents we use, there are pre-flight checks. They give us the absolute precision we need to understand the eye's environment, setting us up for a completely safe pharmacological landing.
So, here's our flight path for today. First up, cellular tracking with vital dyes. Second, halting signals using local anesthetics. Third, receptor control for pupil dilation. And finally, fourth, the clinical big picture.
All right, starting right on the surface. Part 1, cellular tracking, vital dyes.
We rely on two foundational dyes to really map out the ocular surface, and they act in entirely different ways. On the one hand, we have fluorescein. It's a yellow acid dye, loves water, and it specifically highlights the intracellular spaces between living corneal cells, especially when you hit it with a cobalt blue light. On the other hand, we have lissamine green. This one is a phenylmethane dye, and instead of filling spaces, it specifically targets and stains the nuclei of devitalized or damaged cells, and you can see it easily under just normal white light. So together, they give us a complete, highly detailed topographical map of the eye's surface health.
Now, what's really fascinating here is how this completely busts an old clinical dogma. For literally decades, the assumption was that fluorescein strictly pooled in dead or injured tissue. But recent evidence presented in Dr. Boyesen's lectures flips that entirely on its head. It turns out fluorescein molecules can actually enter and leave completely healthy, intact epithelial cells. And here's the absolute kicker. These stained cells still undergo normal mitotic activity. They divide, and their daughter cells maintain perfectly healthy functioning. This is a huge deal because it profoundly changes how we interpret corneal staining. It's not always a definitive sign of cellular death.
And that brings us to the specific tool we use when we actually do want to find cellular death: lissamine green. Unlike rose bengal, which has traditionally been used for the same purpose, lissamine green targets those damaged cell nuclei with absolutely zero carcinogenic or cytotoxic properties. And honestly, the best part for the patient, there is zero stinging when you put the drops in. It's a completely painless way to confirm the presence of dead cells.
Okay, so we've got the surface perfectly mapped out. But here is the challenge. How do we examine these highly sensitive structures or perform procedures like tonometry without triggering the eye's acute pain response?
That brings us to part 2, halting signals, local anesthetics. Let's see how this builds into just an incredibly elegant sequence of pharmacological events. When a drop of anesthetic hits the eye, it's actually in an uncharged lipid-soluble form. And this is key because it allows it to effortlessly slip right across the cell membrane of the nerve ending. Once it's in, it changes. It shifts into a charged form and hunts down a very specific target, the voltage-gated sodium channel receptor. By binding there, it blocks the transient increase in sodium ion permeability. And well, no sodium means no electrical depolarization. The pain signal is literally stopped dead in its tracks before it can even travel to the brain. And the beauty of this specific sodium channel mechanism is its incredibly low toxicity. Even better, these local anesthetics do absolutely nothing to alter pupil size or the eye's ability to accommodate, which makes them the perfect tool for invasive diagnostic procedures like tonometry to check eye pressure or gonioscopy, because they do all the pain blocking without muddying the waters for the rest of our clinical exam.
So, we've mapped a surface, we've blocked the pain. Now for the ultimate question. How do we open the visual pathway to actually see deep into the back of the eye?
Let's find out in part 3, receptor control pupil dilation.
To open the pupil wide, we can actually pull on two totally different levers in the autonomic nervous system. And this brilliantly illustrates the dual pathways we can use. First, we have the sympathetic nervous system, the fight or flight pathway. We can use an adrenergic agonist like phenylephrine, which specifically targets alpha-1 receptors to physically contract the iris dilator muscle, literally pulling the pupil open.
Or we have the parasympathetic system, the rest and digest pathway. Here, we'd use a muscarinic antagonist, like tropicamide. It targets M4 receptors to block acetylcholine, which essentially paralyzes the sphincter muscle so it just can't constrict.
So, the crucial point comes down to this specific number, 5.37. That is tropicamide's pKa value. In pharmacology, pKa basically dictates how a drug behaves at normal bodily pH. Because tropicamide has a pKa of 5.37, it exists mostly in an unionized state at physiologic pH. And unionized molecules, they can penetrate the corneal epithelium incredibly fast. This is exactly why tropicamide has a super fast onset, making it the absolute drug of choice for rapid ophthalmoscopy.
But we do have to be careful with our other key, phenylephrine. It comes with some strict clinical limitations. For instance, it really struggles to yield good dilation in heavily pigmented irises. It's also less effective in diabetic patients, and critically, in patients over 60. Why? Mostly because of arteriosclerosis. The hardening of the radial vessels in the eye actively resists the mechanical pull of an already weak dilator muscle. Understanding these receptor-level limitations is absolutely vital for a solid pre-flight check.
Which leads us to part 4, the clinical big picture. We return to Dr. Buison's wonderful tiger moth analogy. If our clinical exam and our molecular diagnostics are the pre-flight check, then applying all of this knowledge correctly is what ensures we, quote, land safely back on Mother Earth. By mastering these distinct pharmacological mechanisms, knowing exactly when to use lissamine green over fluorescein, or exactly why tropicamide acts faster than other dilators, we ensure a completely safe and highly successful clinical outcome for the patient.
So I want to leave you with this thought. If a single, tiny drop of dye can completely rewrite what we know about cellular mitosis, and if a simple anesthetic can so precisely hijack our sodium channels to just turn off pain, what other molecular master keys are just waiting to be discovered in clinical pharmacology? The eye is a window not just to the soul, but to the intricate biochemistry of the entire human body. Thank you so much for joining me on this explainer, and keep exploring.